Now, we know that there's a study called the CHAARTED study with two A's in the middle, CHAARTED. Somebody worked very hard on that name.
Yes.
I'm sure. It was presented at a plenary session of ASCO in 2014.
Yeah.
It found that including chemo, docetaxel with ADT early in castration-sensitive patients. All right, this is a big pile of conditions in a big group.
Yeah.
It improved the median OS by 17 months in patients with high-volume Mets, right? Improved median time to clinical progression, 13 months. Median time to CRPC was extended by 6 months. All right. So what are the implications of all these results, do you think?
Well, I think the implications are, and I'm going to make some assumptions here, I'm going to assume that those patients who at diagnosis have high volume therapy at which the urologist or the oncologist is saying, I got to think about what I have to do. I have to factor in all these other things.
And this is high volume castration sensitive patients, right?
Yes. Yeah. So they're going to say, how old is this patient? How aggressive do I want to be? Other factors. So I'm going to make the assumption that if you've got high volume Mets at time of diagnosis, you might have a little bit more of an aggressive disease. And it may be that that aggressive disease comes with a larger proportion of cells that are already androgen resistant.
And before we go any further, we might as well get the definition nailed. How do you define high volume patients? We've been throwing that term around.
It's really those who have 4 or more Mets or have visceral Mets, so 4 more skeletal Mets. And I think anyone who has symptomatic disease, you might want to throw them in as well.
Okay, and we want to throw in one other factor.
Yes.
Age.
Yes, sir.
How does age factor in all of this?
Well, if you read the patient literature, and that's important because patients have to make decisions, the patient literature on the NCCN side says, okay, if you think you're going to live 1 to 10 years, even for intermediate disease, often the recommendation is do nothing. And if you're going to live 10 to 20 years, there's a higher level of aggressiveness. And if you're going to live greater than 20 years, the answer is surgery, radiation, androgen suppression.
Go for it.
Go for it, chemo. So that's how age factors in.
You know what's interesting to me, and this is personal communication, unpublished data, Salgo et al. Everybody is talking about evidence-based medicine.
Yes.
And what we've been talking about is a lack of evidence.
Yes.
You know, it's really hard to make evidence-based decisions and then to be restricted on your prescribing based on evidenced data if you don't have the evidence.
Oh, I know. And if you think about the armamentarium for treatment of prostate cancer, we have the LHRH agonists, which have been around for a long time and did great in helping people move to that need where previously they were getting therapies that were so poorly tolerated. So the leuprolides and the trileptins and all those drugs have been great. But then you're moving on to another generation of androgen suppression and blockade, which is abiraterone and enzalutamide. We're a long way off from the early agents, which included even things like flutamide and ketoconazole.
Boy, I remember those. Yeah.
See, you think ago. I'm young, but I'm really almost the same age as you. I remember when ketoconazole was considered an agent that prevented the production of androgens. So we've got these anti-androgens. And now we've got chemotherapy. And if you look at NCCN, you really only have docetaxel, cabazitaxel, and I think mitoxantrone. I mean, there's really not much. And then, anyone who wants to go out on a limb and use immunotherapy, we have the big P for immunotherapy,
right.
Provenge. But there's really not a lot out there.
But you know what's interesting in what you've just said? To me...
This is over 30 years.
Yeah, but we have a lot of data. In other words, what you've told me, if I heard you correctly, is sure we're doing evidence-based medicine.
Yeah.
We've been peeling off stuff
that
the evidence suggests doesn't work. Or doesn't work as well as what we seem to have now.
Yeah,
so there is evidence-based therapy.
Yeah, and I think that what we've learned from peeling back the onion on some of that evidence-based therapy is that we don't know enough. And that we need to get to a higher level of understanding at the genomic level. As you said, what is it that activates pathways to move in an alternate manner under this ecological pressure of androgen deprivation? And who are people who maybe had that environment to begin with? Maybe they do better under that trial that you referenced because they were the ones who were androgen and castrate resistant to begin with. So hitting them with chemo initially, when they were naive to both androgen deprivation and chemo, knocked out most of their androgen resistant cells and allowed their androgen sensitive cells to die on the vine because we also gave total androgen blockade. And I think that's not unlike the observation in breast cancer where older women who have estrogen and progesterone sensitive tumors, they don't really get much added benefit from traditional chemotherapy because almost all of their cancer cells are estrogen dependent.
Dr. Klein, it's a pleasure to have you here with us today.
Thank you, Dr. Salgo. I'm excited to be here as well.